My name is Stefan Schreiber. I'm a clinical gastroenterologist from University of Kiel in Kiel, Germany. And I have a background in translational medicine, which means I'm interested in understanding molecular principles that drive disease. I'm part of the supervisory board, so I give advice, and I also stand a little bit for the patients being available in the different cohorts that are coming from Kiel. My interest is to make the life of patients better. IBD is a chronic disease that at the moment I think cannot be well treated. Only very few patients have the full benefit of a disease control, even using the most advanced drugs. And therefore we need to understand more about the pathophysiology of disease and how we can group patients in a better way to respond either better to therapies or pick the right therapies for them, or even design new ones. IBD is probably a process that runs for years before it surfaces in a way that can be diagnosed. Now, the incompleteness in therapeutic response may be also because it comes too late. We learn on the scale after diagnosed that earlier is better in terms of the intervention. And the idea here is, wouldn't it be better to stop a disease before it has caused any damage, and therefore that transition period between the first onset of disease, when the domino stones started to fall, and the macromorphological damage is just very, very important as a treatment target. These are two diseases with different characteristics, and old clinicians, generation before me, thought these are completely distinct diseases. There's certain clinical and radiologic and morphologic and histologic features that separate the diseases as well, their manifestation, anatomic manifestation in the GI tract. But by today we understand that these may be rather phenotypes that describe extremes in a continuum. So the typical Crohn's disease patients, the typical UC patients, and in between are patients who show characteristics of both diseases. The consequence of having Crohn's disease are obviously very grave because it can affect every place in your GI tract. No operation can heal it, and it causes quite substantial complications like fistula or stenosis. Ulcerative colitis is a vivid and destructive inflammation of the colon, but just the colon alone, which means a rescue is possible by taking the colon out. This is by far not a perfect rescue, but if it comes to living a life, then obviously I would say it heals you with a compromise on your quality of life, but at least you can go on. Some of the Crohn's disease patients cannot do that because it destroys more and more of their GI tract. With the advent of the genome-wide association studies, it became clear that the root causes of IBD, many of these lie outside of the immune system. And so barrier weakness, for example, microbiome have come big into play as factors that can initiate that intestinal inflammation that later then leads to the overt IBD.